Buenas noches a todos aquellos académicos que nos siguen por el Zoom de la academia y a todos aquellos señoras y señoras que no están conectados con nosotros a través del canal de YouTube. Habiendo sido aprobada el acta de la sección anterior, vamos a escuchar del doctor Manuel Montesinos los asuntos centrados. Doctor Manuel Montesinos, tiene la palabra.
Muchas gracias, doctor Matera. Buenas noches a todos. La comisión directiva ha decidido continuar celebrando las sesiones exclusivamente con modalidad virtual. Quedará la presencialidad limitada a las ocasiones que así lo ameriten. Los asistentes a las sesiones pueden registrar su asistencia en el formulario del link que se copia en el chat en vivo, sea en las categorías de miembros de la academia o como no miembros, o también en el chat de Zoom de los miembros de la academia que se conecten por este medio. La asistencia al 50% de las sesiones del año anterior es uno de los requisitos para ingresar como miembro asociado o para pasar de miembro asociado a miembro académico. Los asistentes a las sesiones que no sean miembros de la academia podrán seguir haciendo preguntas o comentarios por el chat de YouTube. A fin de cumplir con el objetivo de la academia, que es el estudio y difusión del progreso de la cirugía, su campo de acción, sus competencias específicas, la comisión directiva enfatiza la necesidad de que los miembros de la academia envíen comunicaciones, casos interactivos y videos científicos para integrar la sábana de futuras sesiones. Recordamos, las presentaciones pueden ser no inéditas. Existe interés en que los trabajos que sí sean inéditos, que se lean en esta academia, sean enviados para su publicación a la revista Argentina de Cirugía. Los manuscritos deberán ser enviados por los autores a la secretaría de la revista. La presentación deberá ajustarse a su reglamento, disponible en la página de la revista, y todos los trabajos serán enviados a revisión por pares de acuerdo con la política de calidad editorial. Trabajos a premio. Debido a los problemas que existieron en la página web de la academia, la comisión directiva ha decidido, en su reunión del 26 de julio pasado, prorrogar hasta el 1 de septiembre la inscripción de trabajos para optar al premio Academia Argentina de Cirugía 2023. Los trabajos deberán ser inéditos, realizados en Argentina, y los autores no ser miembros de la Academia Argentina de Cirugía. Las condiciones están detalladas en el artículo 29 del estatuto que se encuentra en la página de la Academia. Por último, el próximo miércoles 23 de agosto escucharemos la comunicación Manejo de las fístulas enteroatmosféricas, experiencia de 10 años después de 10 años de aprendizaje. Los autores: Daniel Weinstein, Rodrigo Juárez, Florencia Resónico, María Luisa Delfore, Nora Perrone y Pablo Cisco. Nada más.
Muchas gracias, doctor Montesinos. Bueno, y hoy tenemos la suerte y la oportunidad de contar por vía de Zoom con nuestro invitado, que es un miembro de nuestra academia, es un correspondiente extranjero, el doctor Rifat Latifi, que nos va a dar la conferencia Is More Surgery Less or Less Surgery is More? New Trends and Change in Our Surgical DNA. Y ahora el doctor Alberto Ferreres, quien ha hecho el contacto para que el doctor esté esta noche con nosotros, va a hacer la presentación del doctor Latifi. Doctor Ferreres, puede empezar usted su presentación.
Muchas gracias, señor presidente. Y si me permite, antes de pasar a la introducción del profesor Rifat Latifi, que es miembro correspondiente extranjero, quisiera recordar que hoy se cumple un nuevo aniversario de la muerte en este día del año 1953 del doctor Daniel Cranwell, quien en su domicilio se reunió el grupo primigenio y fundador de lo que fue la Sociedad de Cirugía de Buenos Aires, que posteriormente devino en nuestra academia. Y ahora sí, respecto del profesor Latifi, nació en la ciudad de Klodernice, en la antigua Yugoslavia, y actualmente correspondiendo al país de Kosovo. Completó sus estudios de medicina en la ciudad de Pristina, y ahora en un ratito me voy a referir a la extensa carrera que él ha realizado. Y en primer lugar, recordar que Kosovo nació como un país libre e independiente recién en el año 2008. con el apoyo de las Naciones Unidas y los Estados Unidos, y ustedes ven acá en los mapas la relación que tienen con Albania y con Macedonia. La capital de Kosovo es Pristina, y una guerra ardua de liberación de Serbia fundamentalmente. El que ustedes ven ahí es uno de los héroes nacionales, profesor de filosofía, Irvine Rugova, que tuvo un papel preponderante en la guerra por la independencia. Doctor Latifi, como le decía, luego de completado sus estudios en la Universidad de Pristina, completó su cirugía, su residencia de cirugía en dicho institución, y en 1985 cruzó a los Estados Unidos, donde hizo el internado en la Cleveland Clinic con el doctor Bob Herman, que en ese momento era el chair de cirugía. Completó su residencia en cirugía general en la Universidad de Yale en New Haven, y posteriormente un fellowship en cuidados críticos en New York Medical College y en el Lincoln Hospital. Tuvo una dedicación muy importante a todo lo que fue la telemedicina, por lo cual fue el recipiente del American College of Surgeons y el Pfizer International Surgical Volunteerism Award en el año 2015. El doctor Latifi fue profesor de cirugía en VCU, en ese momento el jefe de departamento era el profesor Ronald Merritt, anteriormente había estado en Yale, profesor de cirugía en la Universidad de Arizona, donde ha regresado últimamente, profesor y chair del New York Medical College en Valhalla, en el norte de la ciudad de Nueva York, editor de 20 libros y de más de 450 artículos, y como bien reconoció el premio mencionado anteriormente, desarrollador de la telemedicina y la telecirugía. Él reconoce a sus dos mentores, al profesor Ronald Merritt, totalmente retirado, y al doctor Stanley Dudrick, quien fuera el fundador y el desarrollador de la nutrición parenteral total, fallecido hace 3 años. Volvió a Kosovo, donde tuvo un rol preponderante en la virtualidad durante la pandemia y con el establecimiento del Colegio de Cirujanos de Kosovo. Este es uno de los primeros meetings. Tuve la oportunidad de visitarlo cuando estaba en funciones como ministro de Salud, con distinguidos invitados extranjeros, como ustedes pueden ver, al profesor Pierre-Alain Clavien y a Dimitrios Litwin. Y muy recientemente, el miércoles pasado, lo tuvimos de huésped en el Hospital de Clínicas a través de la Dirección de Docencia e Investigación del Departamento de Cirugía, donde dio grand rounds y también fue distinguido como profesor visitante extranjero. Para mí es un placer y un orgullo su amistad, y lo invito al doctor Latifi a dar su conferencia. Welcome to the Argentine Surgical Academy, dear friend.
Thank you very much. It is my great honor, and thank you, Alberto, for those kind words. Let me just thank Professor Juan Matera, the president, the leadership of our Argentinian Academy of Surgeons, and all members for allowing me to be part of your evening and part of your weekly conference. It is my great honor to be member of this great body that, by the way, was created 1 year before Albania was created as a country. So that means a great deal for me personally. I wanted to talk to you today about a topic that I have been pondering on it for a while. We all know that our lives have changed significantly. Our surgical careers have changed. What you and I have learned during our residency programs have changed dramatically. And thus, we entering a new stage in surgery of kind of minimalistic approach, passing on the problems to the next guy or gal. And I thought that the title should be somewhat provocative. Is more surgery less, or is less surgery more? And are we changing our DNA of surgical practice? I love this. Thank you very much for doing this. I'm going to cherish this ad. I have no conflict of interest except to say that I really love surgery. and love being a surgeon and practice of surgery. That's my biggest conflict that I have. Changes that I will discuss, and these are, each of them are really a topic on its own, but I'm gonna go through is changes in population and demographics and new geriatric practice or new surgical geriatric practice, changing in training, shorter timing and somewhat different attitude, maybe comes with a shorter training, and some clinical scenarios and new trends that perhaps we are adopting them faster than I would like to. So all we have become geriatric surgeons. I am on call today at Abrazo West in Phoenix, and most of my patients on trauma service now are above 70. 70, it's good. 71, one guy looked in pretty good shape, but 80, 82, 90, 92 years old. Then problem number two, issue number two, I think, is approach to a surgical problem. Did we forget the basics that we learned and we taught throughout the years? There are some new rules and regulations that are coming from ACGME and other bodies of American College of Surgeons and American Board of Surgery. There are new technologies, and perhaps we've taken these way a little bit too far. And surgical abilities and expectation of our graduates and now faculty. You all know data, I'm not going to dwell in those papers, that 80% of graduates in surgery in the United States want to go for further training to the fellowship. Now, perhaps one can argue that they want just a solid, more specific life as a surgeon, or may say that maybe we are not preparing them as we prepared ourselves and our professor prepared us. The world is getting really older, no question about that. 8.1 billion people, 10% of them are older than 65. And I looked it up, actually, even in Argentina, as one of the young countries with age, still 10% of the population is getting to be over 65 in a couple of years. And it's predicted that we're going to have 1.6 billion people over 65. I tell everyone a story that we wrote a paper and we sent it to British Journal of Surgery, and we defined elderly over 65. And the very upset editor rejected the paper, saying that I do not accept 65 as old. I am more than 65. I still do not get a pension from the country, from my country in England. So forget it. You're not publishing this paper. It was actually quite an amazing critique. I never seen it once before in all my writings. It is expected that by year 30, 400% will increase the number of people older than 100 years old, 150% those 85, and 100% those over 65. So it is really we are getting older. Here's this slide where younger age is becoming less than old age in 2022. I saw that in Argentina in 2019, people less than 19 years old are now less than old folks. And we projected decline of population in many countries. I was surprised to see this Russia lead this group and continue with other countries around the world. So as the world is getting older, so is clinical and surgical practice and research interests in geriatric surgery. And I personally have taken a great interest in surgical decision-making in geriatrics. emergency general surgery in geriatrics, and we have published a number of papers analyzing the data from nationwide inpatient sample that clearly shows that elderly do worse than young people, young meaning less than 65 years old. For example, in gastroparesis, the mortality is 7 times greater than in adults, 4 times greater than in those with the paralytic ileus compared to adults, and so on and so forth. Chest trauma. Then hospital length of stay independently predicts mortality in patients emergently admitted for esophageal hemorrhage. And again, hospital length of stay, because we now prolong the interventions trying to do different things. But there's some such thing as too much surgery in patients in old population, and perhaps unnecessary surgery. New York Times just published this paper in an article, 2019. The elderly are getting complex surgeries. Often it does not end well. And interesting, on the same newspaper, this has been a subject since 1984, and being advised by the public that we should reconsider major surgery for elderly patients and study or just less harsh surgery for elderly. So there are 2 spectrums of this. One, that we are not operating on time in elderly, and the other one is perhaps we're taking it too far. So surgery has changed and continue to change, but are all changes good changes? That's a question. I mentioned at the beginning, but here are some of the tendencies. Delay the operation as long as you can. And one has to ask, what happened to the policy or practice or things that we have done in the past? Is my patient, my complication. I go and talk to the family. I present to the peer review process if the complications happen, and I take full responsibility. And then we're trying to now do everything minimally at all costs. I told someone today that I booked a gallbladder for tomorrow, and I said we're going to try to do it laparoscopically. I will decide in first 15 minutes if this is going to work or not. Sometimes I see people trying to couple hours trying to get a gallbladder laparoscopically, and in my opinion, it is not the best thing to do. So another way, trying to perform minimally invasive at all cost, and use every auxiliary service to do our job. Intervention radiology, GI, and every other specialty that we usually did as general surgeons. And we all have become shift doctors, shift surgeons. You leave exactly at the time when your time ends. So to summarize, patients are older, frail, and multiple comorbidities. Not so good, but it's a reality. Minimally invasive surgery approach, great thing when appropriate, but not all the time. Changes in training, not sure yet, but by most counts, not good at all. We used to say, and I'm sure each of you said, that not being every night in a hospital, the bad thing is that you miss half of the good cases and education. When I was training, I'm sure you were the same. The general surgeon standard was, I'll meet you in the operating room. Yes, still, in my opinion, if I call a surgeon, my attending, or if my resident calls me, I'm going to say, I'll meet you in the operating room. And I'm not going to say that do some other studies and so on and so forth. So the paradigm was exam. I call it an eye scan, not CT scan. There's no need for that. Make the diagnosis, I'm sorry, there's misspelling there, and admit and operate. Now we do CT scan, make the diagnosis, admit the patient, trying to get some intervention service to do it, whatever that may be, and perhaps we can discharge the patient. Where complications happen, readmit, operate, but perhaps someone else will operate or get lost completely in follow-up. This translates into longer hospital stays, more interventions, more radiological studies, delayed operations, deconditioning of the patient, higher cost, and less surgical expertise. I tell the residents that let's think like surgeons, because we need to operate when we really need. So the question has to that I've been pondering, as I mentioned before, is this what the public expect from us, particularly academic medical centers? Or more importantly, is this what we expect from ourselves as academic surgeons? And did you train so long to do this? Call IR, call GI, and so on. So the question is doing less surgery more? And more is defined as increased mortality, morbidity, and mortality. Drain the perforated diverticulitis abscess, drain the gallbladder for cholecystitis, and I'm not talking just for acalculous cholecystitis, but gallbladder full of stones. Postpone the major hernia repair and let it make someone else's problem, and manage small bowel obstruction conservatively at all costs. Is doing more surgery less. Operate for perforated diverticulitis. Remove the gallbladder for cholecystitis. Manage small bowel obstruction early. And do not postpone that major hernia repair, because I promise you, like everyone in this on this virtual meeting today knows, they do not get smaller. So let's go through some few examples. Acute cholecystitis in elderly. Drain it or remove it. Let me give you this example. There's a patient of mine, elderly gentleman, healthy otherwise, on his way from New York to Tucson a few years ago, felt sick in a plane, had fevers, chills, and nausea. He was removed from a flight in Dallas and sent to the hospital, where he was found to have acute cholecystitis. He was treated with IV fluids, antibiotics, and percutaneous drainage. 3 months later, comes to my office. I did a tube cholangiogram that he had for 3 months now, and saw the gallbladder packed with stones. When I removed it, there were 54 stones packed in the gallbladder. For 3 months, this gentleman had this drain coming with him, going to the doctors, and I'll talk about the drains a little bit later. They have very high dysfunction rate and replacement, from 1 to 10 times. In one study, dysfunction occurred in 132 patients out of 288, or 46% of them, with 80 patients, or 28, requiring re-intervention, while 7 developed procedure-related complications. Excuse me. Medical data of the United States showed PCT, or percutaneous cholecystostomy tubes, have higher mortality. The odds of 30-day and 90-day mortality were significantly higher. 30-day mortality was 39%, and those who underwent tube placement versus 32 on those who had an operation. 90-day mortality was 46% versus 39%, and the 2-year survival rates were significantly lower in those who underwent cholecystostomy tube placement. A recent study from Journal of Clinical Medicine, a systematic review and meta-analysis, 783,672 patients, of them 32,000 received drainage, and 4,063 underwent laparoscopic cholecystectomy. The risk of hospital readmission for biliary complication, hospital stay were lower in a group that had cholecystectomy. So major studies, 17 studies on meta-analysis and systematic review shows that it's safer to take the gallbladder out. And despite being non-invasive, less invasive, it is not associated with lower morbidity with respect to or compared to emergency cholecystectomy. A lower postoperative mortality was reported in patients who underwent the gallbladder removal. So, answer, drain it or remove it? I think remove it, because I don't really know what are we draining. In few patients, we had drained a necrotic gallbladder through the liver just to go back in the belly afterward, after a few days where patient was not improving, to find a dead gallbladder completely. Small bowel obstruction. We try to, with every possible ways not to operate on these patients. Yes, I agree. We have to give them a chance conservatively, but I think sometimes we pushing it way too far. I was part of this Bologna guidelines for diagnosis of management of adhesive disease, and we suggested, or we wrote there, the gastrografin administration is of no benefit in patients with adhesive small bowel obstruction. We have a patient today on my service, an 18-year-old young lady that had a hepatectomy in the past, that we actually gave her gastrografin. And this was, I was discussing this with a resident, but she was clinically doing better compared to sometimes how they do. A meta-analysis, again, gastrografin administration is of no benefit in patients with adhesive small bowel obstruction, and I believe that we wait too long to treat these patients. When you add bowel obstruction and when you add confounding factors like major hernias, you see here on this screen dead intestines that we find on these patients, and they really go from hospital to hospital, episodes of nothing per os, nasogastric tube decompression, Foley catheter, severe deconditioning and malnutrition, gets more severe, and they are told still they do not have peritonitis, and let's give conservative approach a chance. We can examine the patient. We know how to examine, and we should take appropriate measures. So then these poor patients, they really go from hospital to hospital, surgeon or hospital shopping, what I call, instead of home, they are discharged to nursing home, eventually grave, because we were too late to take care of patients. How about appendicitis? 84% present in the first 24 hours. We know that. I don't need to tell you this. But an elderly has a low rate of complications, similar to young patients, and should be offered the operation early. We should really take the appendix out and not do it, not try non-operatively. 106 patients underwent interval appendectomy, and although the overall complication rate was comparable, more intraoperative complications were in a group that went interval appendectomy. So take it first time, take the appendix out, remove it out of the questioning what's going to happen next, or if they have another disease. Today, I'm going to, right from this talk, I'm going to go to the operating room and operate on this woman that has some immune disease and has classic signs of appendicitis. But the CT scan is not, quote unquote, classic. So I urge everyone that appendicitis is a surgical disease and should not be managed with antibiotics and or a trial of something else. How about diverticulitis? There are a lot of questions on diverticulitis, despite the fact that we've been treating this now forever. Is it non-operative or operative treatment? Drain first and cut it out later. later, or just cut it out? Laparoscopic lavage or resect? Cut it out and divert, or perform primary anastomosis, open or laparoscopic or robotic? So a lot of questions. I will concentrate just on few things. I think that those with free perforation was done in either purulent or feculent peritonitis, Hinch stage 4, 3, and 4 should require surgery. I have a patient again on our service now that we just admitted yesterday that has been 7 times in the hospital in the past for diverticulitis. And A, was never offered the surgery, or B, was never told that he really needs an operation. So I think we can do better than that. The morbidity and mortality, then do we really need anastomosis, or can we do we need do we need to do a Hartmann procedure in patient with mild or moderate disease? The morbidity and mortality of primary anastomosis was found to be similar to that of a Hartmann's procedure for patients with even the most severe acute disease. A few years ago in Tucson, I did a anastomosis in a 19-year-old super morbidly patient that I could not bring a stoma anywhere, and he did fine. So I think we probably can do that. ACS national database on 1,300 patients showed the resection and primary anastomosis can be performed safely in acute diverticulitis with no difference in postoperative morbidity and 30-day mortality. So technically, this is more surgery, but in fact is less complications, and I think it should be done. Mixed results on lavage or resection. Lavage never caught in the United States, and I don't really perform that. So final thoughts, more surgery sometimes is less in elderly, and I think we should offer them whenever we have a chance, because this will probably help our patients more. If we had offered surgery in the early stages of these complex abdominal wall defects, and this is actually in the middle, it's a breast disease, gangrene of the breast, they would not come to that. All of these patients are my patients responsible for my reoperative surgery experience, but really this should not be like this. Delayed operation is a major risk factor for mortality among elderly patients in ventral hernia. We analyzed 33,000 patients from a database, and basically showed that the complications were significantly more if they were delayed in operation. And time to operation it's a great factor, as you can see here in our study. So we concluded that delayed operation played an important role in mortality of patients admitted emergently for ventral hernia. Frailty and being male were important risk factors of mortality in most hernias, and age and presence of intestinal obstruction with gangrene were the main risk factors mortality in all hernias. So if we have done it on time, this would not happen to us. There's another real patient, 68-year-old lady with a history of transverse loop colostomy creation 7 years prior to me seeing her from a fournier gangrene. Had a massive parastomal hernia that was been growing or neglected for at least 6 years, being told that she lost the entire abdominal domain. She has a number of diseases, and you can see this one is just a massive deforming hernia. So these pictures what do they have in common? People are called, when are you expecting? If they're female, they think they're pregnant. Do not let anyone to ever operate on you. If I operate on you, we'll die on a table, or you have to live with this for the rest of your life, and drainage fistulas and so on. Let's follow you for a while. So we are not being honest with our patients. We need to tell them that I cannot do it, but I'm going to send you to the Dr. Ferreres, and he will do the operation because he's an expert on this. In summary, more surgery and timely is less. Fix it early, fix it right, perform the definitive operation. If you do not know how to do it, send to the center and or surgeon or surgeons who can do that. I thank you very much for this great honor to present some of my thoughts. And I have to admit I'm quite biased on early surgery and definitive surgery whenever is possible. Thank you so much. I'll be very happy to answer any question and or comments. Would love to hear your thoughts.
Thank you, Dr. Latifi, for a brilliant conference. I'm very clarified to this subject today. Muchas gracias. Bueno, queda abierta la discusión a los miembros participantes en el Zoom, en primera instancia. Hola. Sí. Bueno. Al doctor Alberto Ferreres, su comentario, sí.
Lo hago, quería hacer un comentario, lo hago
I
en
cannot
castellano.
hear, Dr. Ferreres, could you unmute yourself because I cannot hear you.
¿Me escuchan ahora? Sí.
Sí.
Perfecto. Bueno,
I still cannot hear you.
You can, but I unmuted, Rifat. Lo felicito al doctor Latifi por la excelente conferencia que nos brindó. Yo estaba un poco sorprendido por el título de la charla, pero quedó muy bien reflejado con algunos ejemplos. Y yo creo que en el trasfondo de esto está lo que es el adecuado juicio quirúrgico y el conocimiento de los riesgos que enfrenta cada enfermo que se enfrenta a la cirugía. Y fundamentalmente esto hay que contrastarlo y confrontarlo con la experiencia del cirujano a cargo y la experiencia del centro quirúrgico, que es la única manera en que vamos a poder disminuir la incidencia de complicaciones. Así que celebro los conceptos que nos brindaba Latifi, muy importantes para los cirujanos más jóvenes en entrenamiento.
Está muteado, Juan.
Gracias. Muchas gracias, doctor Ferreres, doctor Latifi. You hear the comments of Dr. Ferreres. You could hear finally.
No pude escucharme, me acaba de mandar un WhatsApp, perdóname. Si me escucha, se lo puedo repetir en inglés, como usted decide.
Dr. Latifi, can you hear us?
Creo que no escucha, tiene seteado algo mal en el audio.
Sí, dice que no tocó nada, pobre.
Nosotros tampoco. Se fue.
Ahora desapareció el chat.
Va a intentar volver a entrar seguramente.
Yo creo que sí.
Se desconectó y volvió. Se acaba de desconectar y se va a intentar conectar de vuelta, pero no.
Debe tener mal seteado la recepción de audio.
No logra, me dice que no lograba escuchar a nadie.
Antes de la conferencia podía escucharnos, ¿no?
Sí.
Sí, hemos hablado con él.
Ahí está de vuelta.
Hello, Dr. Latifi, can you hear us? No?
No.
Can you guys hear me?
Yes.
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 I cannot
Yes.
hear you.
Oh,
And I did not touch anything in my hand here.
¿Alguien de la parte de eso que sepa algo más que yo le lo podrá ayudar?
Sí, Lisandro, ¿podés ayudar en algo?
Okay, I can hear you now.
You
Yes.
can hear. Thank you.
Okay. Okay.
Bueno, Alberto, can you repeat the question
Yes.
in English? Yes.
I'm
course.
sorry about that.
Oh, don't worry. Just to congratulate you for your excellent lecture, Rifat. I was a little bit surprised by the title, but now after your delivering your lecture, it's really very understandable. And at the end, I think at the bottom of your concerns lies two issues, which I believe is correct judgment. And there is a big difference between the process of judgment between young surgeons and experts, which includes cognitive psychology as well, and also the knowledge of risks, particularly with the old population. So I think this lecture is a very good example and very good message for young surgeons and surgeons in trainees, as well as expert surgeons. So thank you so much for your excellent dissertation.
Thank you very much, Dr. Ferreres. I believe that we all have learned how to take good care of patients, to be compassionate, to sit at the bedside, to hold someone's hand. We would not give our car to someone to drive it around the block, but we allow a surgeon to operate on us and potentially cause lethal complications.
Mm-hmm.
So I think we need to respect that more than anything else. I was just telling this woman yesterday when I did a gallbladder, she was crying on her way to the operating room. And I hold her hand and made her smile. So the compassion needs to be, and I'm afraid we're losing it. I'm really concerned about it, and we need to not to give up on this. We cannot give up on that. We still need to teach our youngsters that they can be compassionate, and it's okay to cry if you lose a patient or you have complications.
Fully agree with you. Thank you.
Thank you, doctor. Doctor Sun Cheong, ¿puede hacer su pregunta? Estás muteado, Sunjo.
Excuse me, can you hear me now?
Yes.
Okay. Good evening, Dr. Latifi. Thank you very much for your excellent conference. Has been, I would say, very interesting and also, in a way, controversial because, of course, it goes against some of the concepts that are currently finding its ground in surgery. So I must admit initially that I do have a conflict of interest with some of the concepts you delivered this evening, because I do minimally invasive surgery, image-guided minimally invasive surgery, which in other countries and also in our country is also done by radiologists under the name of interventional radiology. But I think this controversy is not as straightforward as it may seem at the beginning, because I understand your concepts are not a mere simplification, but I think your message was do the right thing at the right moment. And I think that's the challenge, to do the right procedure on the right patient at the right time, and among all the possibilities, to use the less invasive possibility whenever this is, of course, convenient. And this concept is applied in many fields with I think with a great success, such as the step-up approach in necrotizing pancreatitis, or doing a bridge procedure such as a cholecystostomy, and then a definite procedure as a cholecystectomy. So I think maybe the mistake is to consider bridge procedure as definite procedure, and that would be, I think, one of the mistakes, or maybe the procedures associated with higher complications. And one thing I would like to ask you is, in countries with limited resources, financial, human resources, maybe there might be a dilemma. And I think at the beginning of your talk, you presented some of these concepts. So when there is a limited resource, you have this dilemma. So if to treat a younger patient who has a longer life expectancy, and to focus on these patients, or to treat the older patients who have a shorter life expectancy. So I mean, as not when the resources are enough for all of them. Of course, both of them have the right to be provided with resources, but from a limited standpoint, what do you think some of the, public health decision makers should be doing in these cases? Thank you very much.
Well, Dr. Hyun, thank you so much for your comments and for questions. I completely agree with everything you said. What I said, and I hope I made it clear, that we've taken it sometimes too far. Let me give you two examples. If you had told me 10 years ago that me, Rifat Latifi, trauma and acute care surgeon, will sit down in the console of the robot to do a gallbladder operation, I would have told you, you lost your mind. Because I'm not going to do that. Because it was taking us 1 hour or half an hour to put the robot in the room. If you ask me now, would you rather do it laparoscopically or robotically? You bet I'm going to say robotically. Can everyone afford $1.3 million machine and then $250,000 a year maintenance of the machine, plus all the expenses that we include? No, absolutely not. Can everyone afford? Argentina is lucky to have you, or your hospital very lucky that you as a surgeon, you do minimally invasive approach using radiologic views. Absolutely. I would love that. But in the right patient at the right time. At 85 years old guy, I believe when he made it to 80, he can make it to 95. There's no reason why not. We are coded to live 120 years. So we just need to do the right things to continue to live. We should offer them the definitive procedure, because it's more in my mind, in my opinion, and I strongly believe on that. There is more suffering of the patient with changing the cholecystostomy tubes, leaking around, having a fistula there. And I've seen those patients. They are miserable. So if you can do it laparoscopically, fine. If you cannot do it open, take the gallbladder out and let people go in their lives so they don't get malnourished and so on and so forth. So from a public health standpoint, I believe you heard that for about a year, I was a minister of health of a small country, Kosova, with only 2 million people. The budget for healthcare system was 266 million euros. The hospital I just left recently in New York had a $1.3 billion budget. I don't know where to send those 266 millions because I need to buy food, bed sheets, beds, lab medication, essential medication, and so forth and so on. So not everyone can afford to do robotic surgery or everything minimally invasive. Absolutely not. I am afraid, and there is some data now, I mentioned it quickly, that 80% of our surgical residents in the United States need to go do a fellowship. In vascular surgery, ruptured aorta now is a deadly disease because unless they can put a stent, they don't know how to do it open. So that is what I'm not fighting for past. I don't, I love the old books, but if I do what the old book says, I will be doing nothing because we need to move on. But just some of the issues that we need to teach our residents and our surgeons in the future. When I had a ruptured appendix as a minister of health, and I ignored it for 5 days, I had the open appendectomy. I was home 2 days after, and I had peritonitis and all that. I went home. 2 days later, I was walking up to the 10th, 8th floor. So it is not as bad as we think if you open the wound. But I love your brilliant. I would love to discuss with you further on these, somewhat controversial, I would say. I agree with your statement before. Thank you.
Muchas gracias. Thank you, doctor. ¿Algún comentario más? ¿Alguna opinión? ¿No? Doctor Montesinos, ahí en el chat, ¿alguna pregunta?
No, no en el YouTube no hay ningún comentario, ninguna pregunta.
Bueno, thank you, Dr. Latifi, for your brilliant conference. We are open our minds about this subject. Thank you a lot, and thank you for sharing with us this evening.
Thank you so much. Thank you.
Thank you so much. Thank you.
Have a good evening, everyone. I really appreciate the honor to be present with you. Thank you.
Thank you very, very much. Thank you.
Bye-bye. Thank you.
Bye-bye.
Bueno, y los invito la semana siguiente a todos a escuchar la comunicación de los doctores Weinstein, Calvi, Resónico, De Forel, Nora Perrón y Pablo Cisco, manejo de las fístulas enteroatmosféricas, experiencia de 10 años, después de 15 años de aprendizaje, y con esto queda levantada la sesión. Muchas gracias.